Top Med Talk.
Nick Majerison here. Welcome to Top Med Talk. This piece is taken from the Perioperative Medicine Shared Interest Group's 2018 annual conference, Measuring, Managing and Minimising Risk, which was held in association with the Australian and New Zealand Society of Geriatric Medicine and the Internal Medicine Society of Australia and New Zealand. Don't forget to check out the show notes on topmedtalk.com for more details. Have a listen.
Right, our next speaker is Dr. Kate Burbury. She's a consultant haematologist, stream lead for myeloproliferative disorders, chronic myeloid leukemia, and lead clinician for haemostasis, thrombosis, and perioperative optimisation, including prehabilitation for all major cancer surgery at VCCC. Thank you.
So thanks to the organisers, and it's an absolutely fantastic session to be a part of, and it's great to follow Toby's talks. Hopefully it'll align in terms of how do we manage those bleeding agents in the perioperative period. I feel very privileged. I'm actually a malignant haematologist, but I landed at Peter Mac for that reason, but I get to work with a wonderful collaborative group of anaesthetists and surgeons, and in fact one of my most favourite parts of my job is the prehab program. So it's great to be a part of this session and show something that is homegrown, that we started in Tasmania and then implemented at Peter Mac and is now part of our organisational culture and fast spreading through other institutions. And it's largely around the management of warfarin, and hopefully something that you can take forward to all of your institutions and implement very, very simply. And in fact, just prior to the session, Toby just asked me what the use of non-oral vitamin K antagonists is in Australia, and I think pleasingly we've taken a far more conservative approach. Warfarin is an excellent drug, and in fact if you compare the data of warfarin versus the NOACs head-to-head in every study that's ever been tested, they're not better than warfarin. They're just better for patients who don't do well on warfarin. So those patients that are stable in terms of their INR monitoring, 60% of the time they do wonderfully on warfarin and actually have better outcomes than the NOACs. The NOACs serve the purpose for those patients that are less stable. And I think that's a really important message so that people don't go out and suddenly change all of their patients to the newer and assumed better agent. So as a result, there's still lots of patients on warfarin therapy, and you'll see it all in your clinic and your perioperative care that patients are still coming through the door on warfarin therapy, and Toby alluded to that in his talk. But perhaps more importantly, and I think again you alluded to it in your talk, is more patients are getting put on it. AF, not only are they getting put on warfarin, but they're getting put on warfarin plus dual antiplatelets. So you need to be aware of these agents as they're coming up to surgery, because minimising bleeding is probably the most important thing you can do in the perioperative period. We've also got this expanded repertoire of agents. It's not just low molecular weight heparin and warfarin anymore. There's growing repertoire of both antiplatelets and anti-thrombotics that you need to be aware of. And really what it comes down to in terms of principles is balancing that bleeding and thrombotic risk. Patients are on anti-thrombotics for a reason. They've declared their phenotype to be procoagulant. So we need to be aware that if you're stopping anticoagulants, you're putting a patient that's already declared themselves to be procoagulant in that state. So we do need to remember that. But equally, surgical bleeding risk can actually delay recommencing those important antithrombotics as well. So getting that balance right is really pivotal. As I said, there's been emergence of anticoagulants, and this list is going to grow. There's millions of arthropods out there that could serve as sources for new antithrombotics. So rather than actually know all about every individual anticoagulant, it's probably more important that you just understand the basic principles behind their pharmacokinetics and dynamics, which I'll touch on towards the end. But I'm going to focus on warfarin for the best part of this talk and hopefully show you some information that will empower you in terms of management of warfarin safely in the perioperative period. I think the most important thing is no one size does fit all. The type of drug and understanding its clearance is important, and what it does. It's important to know that direct thrombin inhibitors also inhibit platelet function, not just anticoagulants. So understanding the patient and the type of drug is really important. Also understanding the type of surgery. Some surgery carries a high bleeding risk. Other, it's not necessarily the bleeding risk, but the repercussions of that bleed, such as in neurosurgery. Also understanding the type of anaesthetic, because that can contribute to the bleeding risks as well as the thrombotic risks. I think the most important thing to say is to consult and communicate, and I think all of you are here because you believe in prehabilitation as being a multidisciplinary collaborative program. So the more that you can get all of the expertise in the room as a virtual room, for want of a better description, to drive these programs is really, really pivotal. Understand the indication for the anti-thrombotic. As I said, if you've got someone who's had catastrophic antiphospholipid syndrome or multiple PEs, actually recognising that their phenotype is higher risk for clotting than it is for bleeding. And dare I say, very few patients die of major bleeding, but there are many patients that suffer major morbidity and mortality through clots. Understanding the onset and the offset of the drug is obviously pivotal. So some of the things that are often forgotten is every medication, including over-the-counter and complementary, can contribute to this. And there's a lot of patients out there, and I work in a cancer hospital, and there's a lot of patients out there on complementary therapies that can impact platelet function, vascular stability, and anticoagulants. So don't forget to ask about that. And also, I think when you're taking these patients to surgery that do have procoagulant phenotype, is actually thinking about how important the surgery is. And I know that might seem like a no-brainer, they're there for a reason, but I think sometimes questioning that, do they need this done now? And I think this particularly becomes relevant in my space and perhaps in your space as well. Someone that's had a pulmonary embolus, actually enabling that patient to wait the 6 to 12 months before you uncover them for surgery can make a huge difference in terms of their perioperative risk, rather than taking them straight to surgery within a 4 to 6 week period after a major clot. And I think particularly in the cancer space that's very relevant, because for many of the upper GI, lower GI and lung cancer patients that will go through what we call neoadjuvant therapy prior to their surgery, that's when they clot. So they'll have a clot in that 4 to 6 week time period, and their surgery is planned for 4 to 6 weeks later. So really important to ask those questions of the oncology team and the surgical team. How important is it to commit to surgery within that time frame, and actually allowing patients that time for their fibrinolytic proteins to dissolve the clot before going to surgery is really important. And being prepared, which I think Toby's articulated beautifully in his talk. So what are the peri-procedural risks? I think the biggest challenge we have is all the data comes from patients on warfarin not going to surgery, or patients going to surgery not on warfarin rather than the other way around. So it is very extrapolated from it, but I think what we can say is what is the risk of a patient that's been put on warfarin for a valve or for a clot when they get uncovered. And we do know that, so that can empower us. And similarly for bleeding risks, they lack direct data that controls it. We know what happens in select cohorts of surgical patients in terms of their bleeding rates, but we don't have really good bodies of data apart from the aspirin space that tells us what happens when you bleed on these agents or off these agents. And I think that's been our challenge to date, but I think with all of these new agents we'll get more and more data, and certainly from a lot of the larger atrial fibrillation studies that compared warfarin to the NOACs, there is some data at least in the surgical space for when patients needed hiatus. So really that's sort of the most important message out of understanding your risks. And I think understanding that hemostasis is multifaceted. It's not just about platelets, not just about clotting proteins. And in fact, the clotting proteins are only there to activate fibrin or fibrinogen to fibrin for the scaffolding. So actually making sure you understand the patient's complete profile, what their fibrinogen is, and so forth. Also taking a really good history is really important to understand the patient's inherent bleeding and clotting risk. This is just a table which I think will be available for you after the talk, so I won't go through it in detail, but it just gives you a feel for what would be regarded as low, intermediate and high thrombotic risk depending on the indication that the patient is on their anti-thrombotic therapy for. It also gives you what their risk is when we uncover the agents for a period of time. Similarly for bleeding risk, and you've all got tables like this in terms of low, intermediate and high bleeding risk. And I think what you need to remember is it's not just about the bleeding risk, but what the repercussions are of the bleed that are really important in that dialogue. In terms of procedures, in terms of risk, obviously time on table is really paramount, whether it's a malignant versus a benign resection, and even within the malignant space, renal cell carcinoma, highly vascular tumours versus what we'd rather call bland or avascular tumours is really important. Understanding the surgical field, especially deep in the pelvis, around the prostate where there's release of fibrinolytic proteins, they're more likely to bleed in those spaces than in the thorax, for example, or around the liver. Surgical technique is obviously really important, and again, I think, Toby, you've touched on that as well. Understanding what the complications are for that patient in terms of a clot and a bleed is really important as well. So warfarin, we all know it, we've known about it for 50-odd years. You're all familiar with it, you know what it does, it activates clotting factors, you know it's reversed by vitamin K, and I think that's really powerful. Understanding an agent and what to do about it is really important. We also have a number of ways of reversing warfarin if we need it. We can stop it It's very unpredictable, but it will wear out after about 5 to 7 days. But we do have a direct antidote in vitamin K, and that's what my focus is going to be today. If you do need to reverse it rapidly, you can give activated factors. And remember, giving Prothrombinix or Novo7, really what you're doing is giving a band-aid of activated factors. They're not antidotes. And as soon as those factors are cleared from the blood, the anticoagulant effect can still come back in. So when you're reversing warfarin, you need to do it in an emergency situation. Giving Prothrombinix is a band-aid. You still need to give an antidote in vitamin K. So this is what the traditional way of managing warfarin that you'll all be familiar with. Patients come to your perioperative clinic, you know they're on warfarin, and then you educate them and say you must stop your warfarin 5 to 7 days before the surgery. They'll get booked somewhere down the track. The patient doesn't yet have their surgical date when it comes to elective surgery. Sometimes you're lucky in your institution, you can plan well in advance, but most of the time patients don't yet know their surgical date, but you ask them to withhold it for 5 days before. So the patient due diligently withholds it for 5 days before, depending on their procoagulant profile. And in fact, was dogma up until only a short time ago, everyone got bridging anticoagulation with low molecular weight heparin. I think one of the challenges was when you're converting someone from warfarin, which is therapeutic dosing, most people got put automatically on therapeutic dose low molecular weight heparin. And you've all seen the data, and that's the major contributor to bleeding in the perioperative space. The patient would then come in the day before to check that their INR had been reversed, because God forbid if they arrived on the morning with an INR still of 1.8 or 2. So they'd come in and get their INR checked before. About 70% of patients might have reached the magical level of 1.5 or below. So then there'd be a discussion about whether or not we give them vitamin K and or Prothrombinix to enable surgery to proceed tomorrow morning. They'd then come into surgery the next morning and get their INR checked and so forth. And I think you've all seen this pattern before. Then we'd restart their warfarin. And one of the biggest challenges we have with warfarin is the longer you uncover them for, the more resistant they are to re-stabilising on warfarin. And that's been shown time and time again. So then you need to bridge them post-op until their INR becomes stabilised in that magical ratio of 2 to 3 or 2.5 to 3.5. It's a very complicated process. And it's complicated by the fact that they often meet you months before their surgery is planned, and then they go back to their regional centres or back to their towns. So there's an unknown quantity. And then they go back to their home after surgery, and someone has to follow up their restabilisation of warfarin. And it was probably being the sole registrar in the Royal Hobart Hospital that made me think we've got to do something better, something simpler. Because I'd get phoned almost on a daily basis, what do we do with this patient? Their INR is still 1.6, 1.7, 1.8, or they forgot to withhold their warfarin. So that's really what drove this process. So I'm going to show you a new way of doing it. I hope I haven't gone forward too far. But anyway, the delegation of responsibility, I think, is another really big challenge. It's perhaps less of a challenge now that we've got these multi-collaborative prehab programs. But patients would come to the surgical clinic and the surgeon would say, OK, this is what you need to do. But it was really the anaesthetist that was in control of that perioperative period. So who holds that responsibility? Who gives them their low molecular weight heparin? But I also wanted to use this as an opportunity to understand what INR meant in the perioperative space, and I'm going to show you some data with that. Because you guys focus on INR, but really what matters is factor levels. So you need to know that when your INR or the patient's INR is 1.5 or 1.4 or 1.8, what does that mean in terms of absolute factor level of 2, 7, 9 and 10? So I'll show you that data as well. So this is our rapid warfarin reversal that we've been using at Peter Mac for about probably close to 8 years now, at least 7, and it is part of our organisation, and there's a lot of hospitals now in Melbourne that use it, and in fact after some discussions at the meeting last year, there's been other hospitals that have approached us to implement it. It's really, really simple. So the alternative method is patients stay on their warfarin right up until 2 days before surgery. They obviously don't have it on the day before surgery, and they get administered vitamin K 3 milligrams. What's made this really easy is the new mycel preparation, which is very safe, very low rates of allergic reactions, and it can be a push. So it can be done in a GP surgery, it can be done in hospital in the home, it can be done in a day unit in a regional place. The most important thing to share with you is the earlier in the day that you can give it, the more reliable it is for the reversal. So we try to get it in before midday, the day before surgery. And I'll show you our results, but we get greater than 95% guaranteed reversal of warfarin by doing this technique. The beauty about it is they don't get preoperative low molecular weight heparin, which reduces the bleeding in the perioperative space substantially. And very few patients need it in the post-operative setting because they restabilise so quickly because we've barely uncovered their warfarin. It also doesn't matter when they come to pre-assessment clinic. It also doesn't matter if they get cancelled or postponed due to emergency surgery. Patients can just continue on their warfarin and reproduce the strategy when their new surgery booking is organised. So I'm just going to show you the outcomes and the simplicity of this strategy. We've probably, have done 1,000 patients like this. It's just routine. It doesn't matter what the indication is for warfarin. It doesn't matter what the surgery is. They've had AAAs, hip replacements, major cancer surgery. We use this technique for every single patient that comes in the door on warfarin going to surgery. As I said, I wanted to look at safety and efficacy of vitamin K because there was absolutely no data to guide you on this. And I really wanted to look at factor-dependent levels as well to guide you on what an INR means, particularly for those for neuroaxial and major surgery. As I said, we used everything. Our INR on the day of surgery, the median was 1.2, and there's the range. 99% have achieved an INR of 1.5 or below. You would not get that with withholding warfarin. You're lucky if you get 70% guaranteed reversal by doing it with that technique. All achieved an INR of less than or equal to 1.7. And more importantly, I think for busy surgical departments and busy elective lists, all proceeded to surgery with no delays. Only gave Prothrombonex to one patient where they wanted the INR at 1.2, not 1.4. So it's been a very robust procedure. I'm going to show you data on 400 patients that has been published, but now that we've got the experience over that period of time, we've more than doubled that. We had one thrombosis in that entire cohort. It was day 9 post major abdominopelvic surgery for quite advanced, locally advanced cancer. They did get appropriate post-operative low molecular weight heparin, and they'd had a recent proximal DVT. We have included it, but it was almost just an extension post-surgery of that event. Less than 20% get post-operative low molecular weight heparin, which is really important in terms of post-operative bleeding as well. And our clinically significant bleeding rates are far below that of what would be seen in the conventional strategy. Our time to restabilise warfarin is short, and I think that's really important for patients who go back to their remote and regional centres or back to their GPs after surgery. And that was sustained at the 6-week mark. I'm just going to show you some graphs more for pictorial representation of what actually happens when you give vitamin K in terms of restoration of factor levels. And that's largely because we know with warfarin we deplete factor levels at a differential rate, and we weren't sure if by giving vitamin K we were restoring them at the same rate, or again there was a differential restoring rate of factors. I think intuitively as a haematologist I know we have inert factors flying around the body, and I was hopeful that that wouldn't be the case. But again, there wasn't that data to guide or reassure you. And what this shows you is by giving 3 milligrams of vitamin K, all of those necessary factors, in particular 2 and 10, were restored to adequate levels for surgical haemostasis, which is greater than 35 to 40%. So here you've got your pre-median and ranges for all of those factors, and perhaps easily more represented in graphs like this. And the reason I've done it like this is we tend to use INRs of less than 1.5 as safe to proceed for neuroaxial or major surgery. And I think what was really nice is if you look at the dotted line that's hopefully coming through at 1.5, you can see all of those factors are well above the 30 to 35% mark, empowering you to move forward with your epidurals or with your major surgery. And this is just showing it in a bigger picture. So for us, it's been really simple. Patients love it. If they've gone through the conventional and needed bridging low molecular weight, they just think this is a revelation in terms of their quality of life. It's relevant for all patients, including neuroaxial anaesthetic techniques. It's not affected by changing surgical dates, which is really important in busy tertiary hospitals. It doesn't require complex delegation. It's literally run by our pre-assessment nurses in our clinic. The vitamin K is delivered wherever the patient lives in GP surgeries, hospital and the home. It's certainly, we haven't done formal cost modelling, but for us it's been profound in terms of resource utilisation. And I think most importantly it avoids the use for bridging heparin, which is the major contributor to bleeding in the perioperative space. I get asked these questions, so I thought I'd just put them up for you. Could you get away with lower doses of 3 milligrams of vitamin K? And I suppose I know from emergency reversal of warfarin that doses less than that only guarantee a reversal of about 60 to 70%, and that's not good enough when you've got elective surgery. You really need to guarantee the surgeon they're going to be able to proceed. We know that you don't need higher doses, so that's really nice. And we know that higher doses are going to contribute to that resistance to rewarfarinization. I've often get asked, should we titrate it according to what their INR is before we give it? To be honest, this is more about efficacy, safety, convenience and proceeding to surgery. And I don't think there's an argument for giving 1 milligram if their INR is 1.8. I think you need to restore enough vitamin K to activate the factors, and that would be 3 milligrams as it is in this case. I often get asked about oral. I think the problem with oral is it takes a good 24 hours and maybe even 36 hours, so again it's less reliable. And now that we can give just an IV push with vitamin K, probably that's taken that complexity out of the management regimen. And as I said, it's extrapolatable to all procedures. So just in the last minute or so, I thought I'll mention these because I know they're all out there and you guys are dealing with this in your perioperative space. They're not new. They're non-oral, non-vitamin K oral anticoagulants. There's huge numbers of patients through huge numbers of studies, so we're getting more and more familiar with them. But they are more complex because we don't have direct reversal agents, and before anyone tells me there are antibody therapy out there that do it, none of them are registered in our reimbursable system. They're expensive, and they're not going to solve the problem for reversing agents, except maybe in the emergency space. So that's really important for us to understand. Here they are there just as a cheat guide, the most common ones, what their target is. Remember, they've got a really rapid onset, so be very cautious about starting them immediately post-surgery, particularly for major bleeding risk surgery. Just hold off, give low molecular weight bridging until you can start it, because once the drug's in the system, it's in the system. Drug interactions are minimal, but they do matter in the cancer space because they work via the P-glycoprotein and CYP3A4 pathways. Again, the most important thing for you to know is time to restore hemostasis, but we've developed some apps, which I'll come to in a minute, that can empower you with that. Recommencing post-procedure, as I said, just be very cautious because their onset of action is so rapid. If you do have to deal with bleeding on these agents, probably the best ammunition is giving activated factor again as a band-aid while you deal with their bleeding through other mechanisms. These are the reversal strategies for these agents. But again, like what we've learnt with warfarin, is acute bleeding isn't necessarily resolved by direct antidotes, and these drugs are highly expensive and haven't proven yet to improve outcomes in that space. I think remember about your bleeding rates and risk factors going into surgery, and it just shows you that in fact the bleeding rates with these drugs are reasonable and definitely higher than low molecular weight heparin and comparable to warfarin, so you don't bleed less on these agents. And the other thing to remember is mucosal bleeding is far greater on the non-vitamin K oral anticoagulants than with vitamin K antagonists, and that can be problematic in tumour-based lesions as well as women that are still menstruating. So this is our smartphone app, and I'm really pleased to show you this today because it's actually only gone live in the App Store this week. We shared with you our STEP app last year, which was a decision-making algorithm in how you prevent post-surgical thromboprophylaxis, and we've had the STEP app implemented at Peter Mac now for a number of years, and we actually took our post-surgical thrombosis rate from 3 times the national average, which is not altogether surprising given it's in the cancer space, to less than the national average, which is something for our anaesthetic and surgeons to be really, really proud of. They use it routinely for every patient going in the door, and this app, which I think complements nicely with Toby's talk as well, is a 4-pronged app. It's management of all of the anti-thrombotics. You basically put a drug in, it tells you exactly what to do in the perioperative period. It's got haematinic optimisation, as Toby has articulated. I don't believe in oral iron either, so it empowers you in what iron deficiency means, particularly functional iron deficiency. I think one of our biggest challenges is I don't think our normal ranges do us justice in terms of decision-making for iron replacement. In fact, there's some beautiful data out of WA looking at different normal ranges for ferritin in different spaces, as well as fast-track warfarin reversal, and that's its name, CLOTS, which is consultation, optimisation and thrombosis prevention in surgery. So on that, I'd like to thank you for your attention, but I really want to acknowledge the wonderful collaborative efforts that exist, because it wouldn't happen without it. And I think what's great to see all of you in the room is this space is becoming more powerful and more effective and is better for our patient care, and it's due to collaborative efforts of all of you in the room working together in the same space for patient care. Thank you.
Nick Majerison here. Thanks for listening to Top Med Talk. Now, before we let you go, it's important that we remind you to subscribe to Top Med Talk. That way you'll never, ever miss another episode. Also, if we could encourage you to join us on social media, Twitter, Facebook, LinkedIn, YouTube, pretty much every single social media platform, we're there. Join us. And finally, check out topmedtalk.com. If you go to our website, you can subscribe to email updates. That way we can always tell you where we're going to be, what we're going to be doing, and how you can join us. topmedtalk.com and click on the section marked email updates. Finally, Top Med Talk is proud to act as the broadcasting arm of EBPOM, Evidence-Based Perioperative Medicine. We'd love you to find out more about them as well. ebpom.org is their website. That's ebpom.org. And if you go to ebpom.org/meetings, you can find out about some of the wonderful meetings that we attend and cover across the year here on Top Med Talk. That's ebpom.org/meetings.